Good morning, dear student. Today's lecture is on circulatory shock. Today I am going to discuss with you the stages of shock. At the end of my lecture, you must able to answer the following. Stages of shock. You have to explain first stages or the non-progressive shock, second stage or progressive shock, third stage or refractory shock. Also, you must able to tell the treatment of shock and about the heart failure. Now, stages of shock. Stages and clinical features of all type of shocks are similar with minor differences. However, hemorrhagic shock is most common type. So we will discuss the hemorrhagic shock first. Depending upon the severity, circulatory shock can be divided into 3 stages. First stage or non-progressive stage, second stage or progressive shock, third stage or refractory shock. Ischemic hypoxic stage, also known as the compensatory stage, stagnant hypoxic stage, reversible decompensated stage, refractory stage, microcirculatory failure stage. Now the first stage of the shock, non-progressive shock. This is also known as the compensated shock. Initial stage of shock occur when there is the moderate reduction in the cardiac output, secondarily to fluid loss or venous pooling or negative inotropic effect on the heart, depending upon the type of the shock. Hypovolemic shock due to acute blood loss occurs when at least 10 to 15% of total blood volume is lost. Thus, about 10% of the total blood volume may be lost without any significant effect. Compensatory mechanism of a rapid onset. This is also known as the short-term mechanism. Compensatory mechanism of a rapid onset immediately set into the motion following the acute loss of the blood and try to maintain the blood flow to the vital organ in spite of the reduced cardiac output. These mechanisms are effective in immediately controlling the blood pressure in non-progressive shock and are followed by the long-term compensatory mechanism which restore the circulatory plasma protein and red cell mass in 4 to 8 weeks. Compensatory mechanisms are rapid compensatory mechanism or also known as the neural mechanism. Rapid or the so-called short-term control mechanism primarily include the following 3 nervous reflexes: baroreceptor reflex, chemoreceptor reflex, CNS ischemic response. As we already discussed about the baroreceptor reflex, chemoreceptor, CNS ischemic receptor, I am going to describe in brief about this. Baroreceptor reflex. When the blood pressure is decreased, there occur decrease in impulses discharged from the arterial baroreceptor. This results in increase in sympathetic vasomotor discharge to heart, arteries and the veins. There occur generalized vasoconstriction. It causes the increase in amount of the blood in circulation. Also, There occur the venoconstriction on account of sympathetic stimulation. This also increases shifting of stored venous blood in circulation, leading to increased venous return and the cardiac output. Chemoreceptor reflexes. Acute hemorrhages cause loss of red blood cell, leading to reduced O2 carrying capacity. The resultant anemia and stagnant hypoxia as well as the acidosis stimulate the chemoreceptor. As soon as the chemoreceptors are stimulated, they excite vasomotor center to causes the increase in sympathetic vasomotor discharge to the heart, arteries and the veins. Fall in the blood pressure below 60 mmHg usually initiate chemoreceptor reflexes. CNS ischemic responses. When blood pressure falls below 50 mmHg, this response is initiated. It causes more powerful sympathetic stimulation. Intermediate compensatory mechanism. In intermediate compensatory mechanism, there is the renin-angiotensin vasoconstriction mechanism. In renin-angiotensin vasoconstrictor mechanism, there is the reduced blood flow, reduced renal blood flow, and this reduced renal blood flow, it stimulates the juxtaglomerular apparatus. From the juxtaglomerular apparatus, renin is secreted. This renin, it stimulates the angiotensinogen. This angiotensinogen stimulates the angiotensin 1. When angiotensin 1 it is activated, it activates the angiotensin 2. Now we know that angiotensin 2 is the potent vasoconstrictor. As it is the potent vasoconstrictor, so in the arteries and the veins it causes the increase the blood pressure. And second important action of angiotensin 2 is retention of the water and the electrolyte. When there is a retention of water and electrolyte, increase blood volume. When increase in blood volume, increase blood pressure. Indirectly, angiotensin 2 also causes the secretion of the aldosterone by the stimulation of the adrenal cortex. This aldosterone, it also increases. Aldosterone causes the retention of salt and water, increase blood volume and increases the blood pressure. So this is how the renin-angiotensin system, it can help to maintain the flow of the blood toward the normal and reduces the shock condition in the previous or in the initial stage only. Then reverse stress relaxation. In the reverse stress relaxation, whenever there is decrease in the arterial blood pressure, decrease perfusion pressure in the blood storage organs like the veins and arteries, then there occur the dilatation of the blood vessels, and this dilatation, it increases the venous return, cardiac output, and blood pressure come towards the normal level. Capillary fluid shift mechanism. Capillary pressure is directly proportional to the arterial blood pressure. Increased arterial blood pressure increases hydrostatic pressure at the arterial end. Fluid shift from capillaries to interstitial fluid compartment. So the arterial blood pressure, it come toward the normal level. Long-term compensatory mechanism. Restoration of the plasma volume and the protein. After a moderate hemorrhage, the plasma volume is restored to normal in 12 to 72 hours. The plasma protein concentration and hematocrit value is actually reduced, which causes the hemodilution. There is a rapid entry of the preformed albumin from the extravascular store. The influx of the albumin and the rest of the plasma protein lost are restored by hepatic synthesis over a period of 3 to 4 days. Restoration of the red cell mass. Excess release of erythropoietin, which increases the rate of cell production in bone marrow within 10 days. Normal cell mass is restored in 4 to 8 weeks. Under normal circumstances, the circulatory compensatory mechanism causes the full recovery without help of outside therapy during the stage of the non-progressive shock. However, the timely outside therapy may hasten the recovery. But if we control the shock during the initial stage only or non-progressive shock, then we can reduce the mortality, or we can reduce the mortality, or we can prevent the patient to go further into the higher complications. Then we come to the second stage of shock, or the progressive shock. This occurs after 15 to 25% loss of the total blood volume. In this stage, the compensatory mechanisms are not able to stop the progression of the shock. Or when we said in the other words, the intense arteriolar vasoconstriction seen in this stage is usually not adequate for maintenance of normal blood pressure. In progressive shock, the structure of the capillary system began to deteriorate, and various types of positive feedback mechanisms develop. So, the therapeutic intervention are essential. Otherwise, this type of the positive feedback mechanism will causes progressive decrease in the cardiac output. Patient will go into the stage of the refractory shock. Positive feedback cycles responsible for continuous progression of the shock, if not interrupted by therapeutic intervention, led into the refractory stage. When we third stage of the shock. Third stage of the shock is also known as the refractory shock or the irreversible shock. As we mentioned that when the shock is in progressive stage and is not treated adequately, a vicious cycle of various positive feedback mechanisms set in and patient passes into the third stage of the shock, that is the refractory shock. Irreversible shock. In this stage, all therapeutic interventions are usually ineffective and eventually the patient dies. The main factor responsible for the irreversibility of the shock is the depletion of high energy phosphate compound, especially in the liver and the heart. Especially in the livers and the heart are greatly diminished in severe degree of the shock. The adenosine triphosphate degraded in the cell to the adenosine diphosphate and adenosine monophosphate and finally to adenosine. This adenosine diffuse out of the cell and is converted to uric acid, which cannot re-enter the cell. New adenosine is synthesized very slowly. Hence, once depleted, high energy phosphate stores of the body cells are difficult to replenish during shock, and this contributes to the final stage of irreversibility. Tissue damages in the refractory shock. Slowly, necrosis of some cells of body set in, especially the cell adjacent to the venous end of capillaries, which receive less nutrition than the cell near the arterial end of the same capillaries. Patchy necrosis first appear in the cells of liver, then kidney tubules, lungs, and then the heart. In the kidney, there occurs acute tubular necrosis leading to acute renal failure and uremic death. Deterioration of the lung often led to respiratory distresses, the shock lung syndrome. Now, we talk about the treatment of the shock. The treatment of shock is aimed at correcting the cause and helping physiological compensatory mechanism. So, elimination of the initiating causes of the shock, for example, anti-infection, stop bleeding, anti-anaphylactic reaction. Then, restoration of the blood volume. It is done by intravenous administration of normal saline, glucose solution, blood, plasma, and so on. Oxygen therapy may have some beneficial effects. In general, it does not have marked effects since the hypoxia of shock is of anemic or stagnant type and not of the hypoxic type. And this oxygen therapy is given only in severe condition involving reduced oxygenation of the tissue. Administration of the drugs. Sympathomimetic drugs like epinephrine and norepinephrine are useful in neurogenic and anaphylactic shock. In traumatic and cardiogenic shock, dopamine is used. Glucocorticoids are administered in the severe cases. These glucocorticoids, they increases the strength of the heart in last stage of the shock. By stabilizing lysosomal membrane, they prevent release of enzymes of cell, and these help in metabolism of glucose by the severely damaged cell. By changing the posture. This is the first measure to be taken in case of hemorrhagic and the neurogenic shock. The head down position, it increases venous return cardiac output, and cerebral blood flow. This should not be used for longer period because prolonged head down position might affect the ventilation. Now the heart failure. Heart failure, it is the pathophysiological state of the heart. When the cardiac performance is too low to maintain the cardiac output to meet the demand of the metabolizing tissue. Types and causes of the heart failure. Heart failure can be classified by various ways. Types and causes of heart failure depending on the involvement of the site of the heart. Left heart failure. Reduction in the left ventricular output leading to elevation of left ventricular volume and the pressure and its transmission to the left atrium and pulmonary veins. Condition causing left heart failures are left ventricular outflow obstruction, which is because of systemic hypertension, aortic valve stenosis, coarctation of aorta. Left ventricular inflow obstruction due to mitral stenosis, reduced ventricular contractility due to anterior wall myocardial infarction. We can classify the heart failure also by the depending on the onset, whether it is the acute heart failure or the chronic heart failure. Acute heart failure develops suddenly as in patient with myocardial infarction. Chronic heart failure develops due to gradual deterioration of the heart function as in the patient suffering from the valvular diseases. Right heart failure. Reduction in the right ventricular output leading to rise in right ventricular and right atrial pressure. So rise in jugular venous pressure, edema, congestive hepatomegaly and congestion of viscera except lungs occur. Biventricular heart failure, or that is known as the congestive. There is the stimulation involvement there is the simultaneous involvement of both right and left heart due to disease of myocardium or left ventricular failure after some time involves the right heart also. Systolic and diastolic heart failure. Systolic heart failure occurs due to poor myocardial contractility. Diastolic heart failure results due to poor ventricular filling because of defective relaxation. Both systolic and diastolic heart failure coexist, particularly in myocardial infarction. High output failure and low output failure. High output failure is a state in which cardiac output remains high at the upper limit of normal cardiac output, that is 3.5 liter per meter square per minute, even though cardiac function are depressed. Various conditions which result in the high output failures are fever, thyrotoxicosis, anemia, beriberi. Low output failure. In this stage, cardiac output remains at its lowest limit that is 2.5 liter per meter square per minute at rest, and in stressful condition becomes further depressed. As in case of the heart failure secondary to ischemic heart diseases, hypertension, valvular and the pericardial diseases. Clinical features depend on underlying diseases and type of the heart failure, and these are features due to the low cardiac outputs are fatigue, hypotension, poor tolerance to stress and oliguria. Left heart failures are features of left heart failures are cardiomegaly, cardiac arrhythmia, dyspnea or orthopnea. Features due to right heart failures are rise in jugular venous pressure, hepatomegaly, peripheral edema, ascites and hydrothorax. Features of chronic heart failure: raised jugular venous pressure, edema and congestive hepatomegaly. So these are all the clinical features of the heart failure. When we talk about the treatment, the basic principle of treatment of heart failure are aimed to remove the precipitating factor, correct the underlying causes, control the congestive heart failure state and prevent complication. In general, following measures are employed as a treatment of cardiac failure. To reduce cardiac workload, for this, complete bed rest is advised or patient is hospitalized for 1 or 2 weeks. Small and light meals are recommended and the drugs like sedatives and anti-anxieties are prescribed. To improve myocardial contractility, drugs like cardiac glycosides, that is digitalis, and sympathomimetic amines are prescribed. To control the fluid retention, dietary salt intake is restricted and diuretics are given. To reduce afterload, use of vasodilator drugs, especially angiotensin converting enzyme inhibitor, that is captopril and enalapril is recommended. So this is all for today's lecture. Thank you.